Good afternoon, everyone, and welcome again to the SCAGO 2023 Summit. My name is Ewurabena Simpson, and I'm a pediatric hematologist oncologist at CHIO in Ottawa, and I'm also co-chair for this wonderful meeting today. So thank you again for being here. And I'll be moderating today's equity plenary session on mental health, intersectionality, and sickle cell disease. If you or members of your network would like to refer back to the information shared in the session, a recording of today's session will be posted on our website at sicklecellanemia.ca for viewing at your convenience. In this session, we'll be hearing from Dr. Oyedeji Ayonrinde, who I'll introduce shortly, and you can also visit the SCAGO speaker page to see his more detailed biography. So today, I'll start briefly with some housekeeping rules, which will be followed by the presentation. So first of all, we'll just ask that you save your questions, thoughts, or concerns until the latter portion of our session, where our guests will be able to answer questions individually. We kindly ask that you respect the learning being done in the space by abiding by the following housekeeping rules. So firstly, if you'd like to ask a question, please do so by putting your questions in the chat or Q&A function, or by raising your hand. We'll try our best to answer all questions during today's session. Secondly, translation captioning is provided at the bottom of your screen. And thirdly, we ask you to use respectful language in the chat, and there should be no profanity or inappropriate images or posts, please. Fourth, please do not post other material unrelated to today's topic. And finally, keep discussions and comments on topic as much as possible. SCAGO does reserve the right to pause the session or to seek removal of participants who did not abide by these rules. Thank you for your understanding and agreement to positive participation. So now I have the pleasure and honor of welcoming Dr. Oyedeji Ayonrinde. Dr. Ayonrinde is an associate professor in the departments of psychiatry and psychology at Queen's University in Kingston, Ontario. He's also the chair of the Commission on Black Medical Students at Queen's University. His specialist training was at the Maudsley Hospital and Institute of Psychiatry in London, UK, with an MSc in Research and Psychiatry at University College London, as well as an executive MBA from Imperial College London and a diploma in the history of medicine. Dr. Ayonrinde has research and advocacy interests in global mental health with reference to marginalized and equity-seeking populations, such as individuals with severe mental illness, racialized groups, and people living in poverty with local, national, and international collaborations. Alongside research and publications in these areas of interest, he has received several education and knowledge translation awards. Dr. Ayonrinde is a fellow of the Royal College of Psychiatrists in the UK, an international fellow of the American Psychiatric Association, a fellow of the Royal Society of Arts, and a member of the Society of Apothecaries. He's a recipient of the Freedom of the City of London, England. We are very fortunate to have Dr. Ayonrinde here to present his work and to share his knowledge and expertise. Welcome, Dr. Ayonrinde. The virtual floor is yours.
Thank you so much, Dr. Simpson. Quite an honor to join you at SCAGO this year. I'll share my screen. Thank you. I hope you can see the screen. Great. Well, thank you for the invitation to speak today, and I'll start with my summing up comments. So if all you need to hear for this afternoon, your takeaway point is that actually mental health is part of the sickle cell syndrome, and that the intersections between mental health, sickle cell disease, and people who live with health challenges is so tightly interwoven that we cannot and must not ignore mental health as part of the whole disease condition. I have no conflict of interest to declare. However, in the spirit of shared learning, my greatest medical learning in the last 9 months or 10 months has actually been experiencing long COVID. And I've had the educational experience you can never learn in medical school of developing heart disease, having difficulty with breathing, seeing specialists in hospital, being under investigations, and all sorts of medical interventions. Now, why I say this is because for all the expertise we may have as physicians, health professionals, and so on, There's something about lived experience that gives an expertise beyond, way beyond what you can ever learn in university, college courses, and so on. So I'd like to use this presentation to honor all those with lived experience, those with living experience, those who have departed, and through their journey, the loss and the pain have educated us, and we honor their memory as well in our understanding of sickle cell disease and mental health. The brain is a very complex organ, and it's networked and connected in many ways. And in a way, if we think of all of us attending this amazing conference, connecting from different parts of the world over the internet with different backgrounds and different areas, likewise, this is what happens in the brain with interconnectedness. And the complex activities from Africa to Europe to North America, the Caribbean, Asia, Australia, and so on, are the complex neuronal networks and how these may affect us in our mental health as well, particularly if we are experiencing sickle cell disease. Perhaps we can start with a premise that no one enjoys 100% mental health all the time. So we may have good days, not so good days, but no one feels excellent all the time. So hopefully, if you're in the right place, we all experience mental health to 100% minus a factor of X. Now, in the title was also the word intersectionality, and this is something we have heard so much of recently. So I'll touch on this as well, just to add some context. Intersecting identities, the challenges of coming from different belief systems, value systems, and how they overlap with how we look and our stance in life, our life experiences. The challenges we go through with negotiating our identity. Is it the same thing being Black in Lagos as, well, you're not really Black in Lagos, as being a person in Lagos and finding yourself Black in Toronto, and so on. And how do we negotiate these different identities? And the concepts, which I hope to refer to further, of identity safety. How much are we living with sickle cell, providing support for loved ones and family, and providing care? How much are we our most authentic selves? Do we demonstrate identity safety, or do we hold back? And if we're holding back, why? Now, the concept of intersectionality was described by Kimberly Crenshaw in 1989. And just some key points being intersectionality touched on a person's social and political identities and how they combine. Multiple factors that may give us advantage and disadvantage. Gender, caste, sex, race, how we look, our faith, whether we're experiencing disability, our weight, appearance, height, and this may be empowering and oppressing. And these can be as subtle as things of intersections to do with not only how we look, but how we sound. It could be a person's accent and the advantage and disadvantage that may give. A quick illustration, if I code switch to speaking with a more Nigerian accent, and I continue to talk to you like this, will I give me privilege or not privilege in some situation? And that can change. And these are the challenges with intersectionality, because this is the way we might interact with situations, whether it's in hospital, with care, education, and so on. So in the slide you see here is a gentleman, but we don't know if that's the person's chosen identity. We see the person on a wheelchair, and here maybe multiple intersections. And it's important to note that many intersections we will not be aware of unless the person shares with us. So what's the person's gender? What's their preference, political, faith, and so on? We don't know. And it's safe to assume when we meet people and interact with them, we barely know them, they're strangers, till they feel safe enough to share enough with us to help us have a better insights. So I'll storytell through some of this. Babies come from somewhere. People fall in love or they have sex, someone gets pregnant, and a baby arrives, stating the obvious. But with the love that comes with a child come all sorts of expectations. And when a child is born and tested and is found to have sickle cell disease, what does this mean for the whole family, each individual? Now, the way a child looks may not all describe their whole experience. So here's a cover from National Geographic. You've got twin sisters, but the way the genes landed were different. One twin here looks black, the other twin looks white, but they're twins. And this, their appearance, may actually determine their life trajectory from cradle till grave. So what's it about how we look, our mental health, and these intersections with sickle cell disease? Many people living with sickle cell disease or within families go through loss events, loss of day-to-day physical health, loss of mobility with some people, periods of illness away from school, loss of education or educational hours. For some people, loss of dreams or aspirations, loss of social activities, loss of employment, loss of quality of life, and loss of life in some cases with variations in life expectancy. So at the default of being or living with sickle cell or being a family member, loved one of someone with sickle cell, is dealing with loss over and over and over again. I wasn't able to go to Johnny's birthday party because I was in a crisis. I'd missed that activity in school. I didn't get to play in the sports team. And this gradually gets embodied into sense of being othered and being on the outside, being different. If we link this with the concept of mental wellness, which involves physical, psychological, social, and spiritual well-being, how does sickle cell disease then take a toll on our mental wellness? Anemia, for instance, the low blood counts, feeling weak and exhausted, difficulty with school, unable to play sport, football, feeling left out, feeling lonely. If I live with periods of repeated loneliness in situations like this, how does that build my own self-esteem? Or I feel left out. Pain and the impact of pain with missed work, unable to concentrate, feeling depressed, losing a job or financial problems. A lot of people find it difficult to put themselves in the experience of the other person. And I would encourage you, if you've never had sickle cell related pain or a pain related disorder, imagine yourself with a very severe toothache and what it's like then for that toothache to stay on for days and days, if not weeks. It'll ultimately take a toll on mood. Sickle cell disease can be associated with stroke and seizures, and these can have direct impact on brain tissue as well, and the mental health consequences that may follow that. Anxiety, worry, palpitations, poor concentration, inability to sleep, and anticipation of more difficulties. Depression characterized by low mood, low energy, impaired attention, concentration, memory not being great. In some situations, feeling hopeless, worthless, not enjoying things previously enjoyed. And in some situations, sadly, suicide or suicidal thoughts. For those who live in the Northern Hemisphere or countries like Canada, there can also be seasonal effects on mood, known as seasonal affective disorder. And it's not the temperature, but it's actually the lights. Reduced sunlight exposure daily can have a direct impact on our mood. And in those situations, the person has a dietary change, they sleep different. And the combination of temperature and seasonal mood effects on a person with sickle cell disease can impact mental wellness too. Sleep disorders, not uncommon. Sleep disorders happen with depression, with anxiety, with pain, trauma, caregiving, mother, father, partner with a loved one going through sickle cell difficulties, may worry and not be able to sleep as they're given loving care. Sleep apnea as well can occur. So many people living with or with lived experience and living experience of sickle cell disease live with trauma. Many have had the most traumatic experiences in healthcare. Some have witnessed the loss of life in other situations. Many have been traumatized outside healthcare as well. And we need to ask ourselves, is there any intervention within our hospital, our health system, that's perpetuating trauma to someone who may be already living with the trauma of the illness? And are they developing post-traumatic stress disorder with nightmares, flashbacks, avoiding being in situations that trigger them, and so on? Psychosis. While not common, sickle cell disease and the sequelae, the consequences, can lead to psychotic episodes, particularly blood supply to particular parts of the brain get compromised. Or in some situations with the use of substances, there may be psychotic episodes as well. Loss of touch with reality, and the person may even hallucinate. Psychosis may occur with treatment as well. And these experiences require utmost sensitivity and care. Part of psychosis may also be the experience of delusions, belief systems out of keeping with reality. The human brain can play tricks on us, and we like our brains to give us order. So for instance, you see red written in green, you see blue written in red, you see green written in blue. And by default, unconscious biases, our brains are going to want to bring order to this. And this will also do with humans. So any of us can be biased in an unconscious way without even trying. But with this can come stigma. A lot of people with sickle cell disease live with stigma, which also has a toll on mental wellness. External or internalized with loss of self-esteem. I'm not good enough. I'm never going to be in a relationship. Who cares for me or loves me, and so on. And a sense of not belonging, which has happened from school, the playground, parties, losing friends and being othered, being on the outside, even in the workplace without accommodations. Diagnostic overshadowing. And diagnostic overshadowing is when one diagnosis takes so much precedence that other presentations, when the person sees a clinician, get ignored. So with diagnostic overshadowing, the person says, I have sickle cell disease, and no matter what else they say, all that's being seen is sickle cell, or the person has a mental illness, and all the people see is a mental disorder without giving enough care and attention to the other symptoms. The molecule you see there is what makes people like me black. That's melanin. And what does race have to do with that? The experience of racism reported by people with sickle cell disease is significant, particularly in situations where there may be minority groups, othered, marginalized. And I put the words micro here in brackets because the insults, the person going through racial insults, it's not a micro. The person being invalidated in the workplace or at school, it's not a micro invalidation. The person being assaulted, verbally or physically, it's not a micro assault. Racism has a direct impact on mental health. And with the number of people of color with sickle cell disease, albeit not all, is a very clear risk factor for mental health issues also. Many of us with sickle cell live with unseen layers, and unless we ask the questions, peel back and build trust in space to have these questions asked and answered, we will not know what each person is dealing with, or the families, the carers, the parents, and so on. So we should assume every single person we work with sickle cell disease, in fact, every single person we meet has unseen layers, and it's only with trust and the safe space that we can unpeel these. I won't go over these in any length, but to health professionals out there, this is the GAD-7, Generalized Anxiety Disorder, 7-item scale. feeling nervous, worrying too much, trouble relaxing, so on. This takes barely minutes to administer. And I implore us to actually apply. When we see people living with sickle cell, the GAD7, check out, do they have an anxiety disorder? Are they suffering with anxiety-related symptoms? Or the PHQ-9, which is used for assessing or screening for depressive symptoms, hopelessness, worthlessness, and so on. Again, this takes only minutes, very easy tools. If nothing else for the health professionals here, the GAD7 and PHQ-9 should be a compulsory tool in the care of people with sickle cell. Medication. Medication can interact quite significantly. Medication can use for anxiety, can worsen symptoms in some cases. Antidepressants come with their own side effects. For those who may have psychosis, they may also have side effects from their medication. And then we've got the sickle cell medication for pain and so on. So we've got sickle cell disease, pain meds, other medication that the person may be using, and then their mental health meds causing quite interesting interactions. I've seen situations where a person's being asked whether or not they were stoned or under the intoxicant effects, just from medication side effects. Substance use, whether perceived or actual, can be complex. And over, we hear people with sickle cell telling us they were suspected of misusing substances or seeking opiates and opioids and other drugs when they were in emerge. I would say, out of just sheer respect, we shouldn't assume a person seeking pain medication or other medication is doing it to try and get high. Honor and give the person dignity enough to feel that believed when they are reporting these until proven otherwise. They're not trying to seek street drugs. And the stigma, the additional stigma upon all the other points I've made can be harmful. We're not saying some people don't develop substance dependence or dependence on various medications, but till proven otherwise, we shouldn't make that the assumption. So I put it to you, the sickle cell disease has both physical and mental health consequences, and we've heard some examples. Psychological therapy is one of the ways we in mental health support people. But do people feel safe enough to seek help? Is there advocacy? What type of therapy? Is it in person or is it online? And if it's online, is there equity? Do they have the privacy, the internet access, and so on? And we need to give very careful thought to psychological therapy and support from people who understand sickle cell itself and also can support the intersecting identities people have. A call to action, policy for mental health. We applaud Ontario Quality Standards team that incorporated mental health considerations into sickle cell disease interventions as a quality standard. Great job. Government policy, we heard Senator speak earlier today, and people who can shift the levers to enhance mental health in their various ways, and innovation as well. Now, here's one innovation that fails to support people with sickle cell disease if they're of color, if not used appropriately, because there's evidence for 30 years that the pulse oximeter is not as reliable with darker skin than with lighter skin. We have a lot more to do. I know what it's like using one of these, by the way, with non-COVID. So with sickle cell disease and mental health issues, we have intersectional fingerprints. Each of us is different. Identity is not homogeneous. Not all people of color or people with sickle cell are the same. There are multiple intersectional identities, and the visible features may overshadow the individual characteristics. So let's create safe space to get to know people and support their mental health as they also deal with sickle cell. These innovations are already happening with emojis and so on. People use platforms like Zoom, and now we have different colors. So let's keep innovating into that space. Final slides. If everything we deliver from the get-go is equality, by default, we're systemically building inequity. I use this image. If everyone got exactly the same bicycle, then we're delivering inequity from the get-go. So for those who start with equality without equity first, equity is the work you do to deliver equality and the adjustments you make for each individual based on their different intersections. We can, with the best of intent, deliver an inequitable health system for people with sickle cell and mental health issues. We applaud those systems that have navigators, where opportunities for allyship and advocates, those with lived experience of sickle cell disease. And I gave a personal example. I've learned more from long COVID than I could ever learn in medical practice. And there's a wealth of expertise amongst people with sickle cell disease to improve us. Health systems, human rights, and other forms of support are also interventions that can support mental health and sickle cell. Time's getting tight, so we're not going to spend all the time doing this. But as we ground ourselves at the end of this presentation, just those opportunities to look at how we can be mindful. An example here being the 5, 4, 3, 2, 1. Thinking of 5 things you can see. 4 things you can hear. 3 things you can touch. 2 things you can smell. And 1 thing you can taste. These sort of exercises when we're anxious or in situations where we feel troubled may be able to help us ground. And it can be fun as a family activity also. I did that a bit quick, but the concept, and I hope you have access to the slides afterwards. As a call to action, as we wrap up this presentation, a call to action is that we develop a sickle cell mental health service care index. SCAGO and other organizations can begin to rate organizations on how much commitment they are providing to supporting mental health care, assessment and care amongst people with sickle cell. And wrapping up, sickle cell disease can have significant emotional and mental health consequences. Some research suggests that anxiety and mood disorders amongst people with sickle cell can be 18 to 46%. But a call to action to all of you today is, don't take these figures, measure your own. What's the rates of anxiety and mood disorders amongst people with sickle cell where you are? 18 to 46%, more than some of the other symptoms of sickle cell disease. Thank you very much. And a reminder, sickle cell disease is a physical and mental health disorder that has a huge toll on quality of life of individuals and their families. Thank you.
Thank you so much, Dr. Ayonrinde. That was an excellent presentation, and you had, 20 seconds to spare on the time that you were hoping to keep to. So thank you so much for this. And it really was inspiring and educational in terms of really considering the intersections of mental health with sickle cell disease. And I think that as providers and as individuals living with sickle cell disease, this is something that really resonated. And so I invite everyone to bring their questions forward. You can ask questions through the Q&A, or you can also raise your hands, and then we can also give you the opportunity to ask your questions aloud. And I guess I can get the question period started. And so, as a physician that provides care to individuals living with sickle cell disease, one of the major areas that we struggle with respect to resources is psychosocial supports. And, my practice is pediatric, but it's often very challenging not only to identify children who are affected with mental health issues, but once they are identified, finding resources to actually support them in terms of psychological or psychiatric care. So do you have any suggestions about how best to firstly screen for these different mental health issues in children and adults, and then how to advocate for more support?
Well, thank you very much. I'll say a starting point will be health education. And every single person within their first year, or in fact from high school, should have awareness of sickle cell. Enough curiosity and understanding of the disorder and the disease in such a way that people can appreciate the challenges people go through. You gave the example of pediatric practice. Many times, for every single appointment, little Deji, I'll use my own name, spends in a pediatric clinic with mom and dad during school hours on a school day. That's Deji not being in class with his friends. I get back to school and they've been playing and having fun, and I may be hurting. They're on the ground playing, let's say, football or soccer, and no one chooses me to play in the team. And it's a lonely beginning. And I would say in the much younger ages, through play therapy, and get the sense of how the person feels about these situations. And as the person begins to build up vocabulary around their mood and the way they feel, the use of stickers. Is it a smiley sticker, a sad sticker, and so on? And get a sense of the emotional state the person's in, yet helping build the confidence and self-esteem. Because self-esteem is a delicate flower. And if one starts feeling odd through having a chronic health condition, racism, being othered and left out so early in life, it's tough. So I gave the examples, the screening scales, the PHQ-9, the GAD-7, for those who have the literacy and the ability to write or use those sort of scales. But there are other versions, and we can certainly begin to build a set of tools that can be used for screening that are age appropriate and culture appropriate. Thank you.
Thank you so much. And we have about 3 minutes left to the official end of the session, but we have 2 live questions, and we've also put up the polls for everybody to give their feedback around this session. So we're asking you to multitask a bit. But for the questions, I'll read them out loud. So firstly, which form of psychotherapy has been found as most fitting for people living with sickle cell? And then the second question is, how can pains of mental origin be distinguished from pains of purely physical origin?
Yeah, I'll start with the second question first. I'll try to respond to both. So I think it's safe to assume all pain is real to start off with. One of the things that adds additional pain to pain is invalidating a person's pain. If I say I hurt, whether it's emotional pain or physical pain, don't try and catch me out. I'm telling you I hurt. Now, it may take some time and trust and safety to discern how much of it's physical, how much is emotional. We know physical pain will or can cause emotional pain. So it's safe to assume that. But sometimes we need just very careful thinking through. Is a person scared they're about to die? Are they dealing with other things? And so it's important we acknowledge all pain is real, whether we can identify the source or not. If a person hurts, it's not for us to invalidate their hurts. The question regarding psychotherapy and the most fitting for people with sickle cell disease, a lot of it will be dependent on the core issues. I think at the most basic level, supportive psychotherapy, just being there with, meeting the person where they're at and validating their experiences and making the sort of psychosocial supports that are supporting them in those ways. There are more specific therapies like cognitive behavior therapies as well that are specific to pain, cognitive behavior therapies that are specific to other types of mood disorders and anxiety disorders. Now, where it's quite different in sickle cell is if a person is going through some of these cognitions, it's not because it's not because they're generalizing those feelings. The unique difference in things like cognitive behavior therapy for someone with sickle cell disease is the fact that they do have a health condition that is authentically impacting on those areas of their lives. And sometimes the psychological or psychotherapeutic interventions, also behavioral, on strategies around problem solving, self-esteem issues, and so on. Short answers to very long questions, and those are actually a whole forum.
Right. Yeah, absolutely. And we'll definitely bring you back because this was really a powerful and very informative session. So thank you so much. And I'm sorry that we have to end, but we have to bring this to a close. And I do invite everybody to join the closing plenary in the other room where we'll talk about from Health Canada submissions of public reimbursement and learning about how to advocate for drug and device approval. But thank you again, Dr. Ayonrinde. This really was excellent, and it was a pleasure to listen to you today and to learn from you.
Thank you, and thank you to all those who try and train us become better carers. Thank you.
All right, see you soon, everyone.